Our third presentation is entitled Resuscitation from Out-of-Hospital Cardiac Arrest. When does End-Tidal CO2 reliably associated with return of spontaneous circulation, presented by Dr. MJ Nassal from The Ohio State University.
Thank you for the opportunity to speak today. This is an incredible honor, and I appreciate everybody's time. These are our disclosures. So cardiac arrest is a leading cause of morbidity and mortality globally. In the United States, 400 to 500,000 individuals suffer a sudden cardiac arrest each year. Of those individuals, we only actually get a return in pulses, or ROSC, in 40% of individuals. And actually only 10% survive to their hospital discharge. So how do we help these people, and how do we improve their outcomes? The American Heart Association actually produces guidelines to help guide interventions and improve outcomes. And when we go through these guidelines, they actually recommend the use of end-tidal capnography during resuscitation, but this is classically for advanced air replacement confirmation. Over the last 20 years, different groups have actually suggested spot checking end-tidal capnography during the resuscitation because they correlated discrete capnography values with outcomes. Last year, we published a new perspective of capnography over resuscitation. So here in these graphs on the left, we have patients who do not obtain ROSC in gray, and on the right, we have patients who do obtain ROSC in blue. And what we see is that over the entire resuscitation, our capnography values for our non-ROSC patients are on a downward trajectory. In contrast, patients who do obtain ROSC have an upward capnography trajectory. And when we perform a mixed effects model and adjust for all of the classic criteria that affect outcomes from cardiac arrest, we found that the upward capnography trajectory was one of the most associated factors with ROSC. What remained unknown, though, was the minimum capnography observation time I needed to watch to predict outcomes. So we set out to do a secondary study. We wanted to determine how long we need to observe capnography trajectories to clearly differentiate an upward capnography trajectory patient from a downward capnography trajectory patient. To do this, we performed a retrospective secondary analysis of data that was collected in the PART trial. The PART trial concluded in 2017, and it compared the effectiveness of endotracheal intubation versus King LT on 72-hour survival in out-of-hospital cardiac arrest. During this trial, physiologic data was collected on defibrillator monitors. My collaborators at the University of Basque Country actually developed a validated and automated process of analyzing all of the physiologic data from all three manufacturers of defibrillator monitors. So we have an efficient and effective way of annotating each of the ventilation's capnography values and summarizing them into 1-minute epochs. I included cases that at least had 1 minute of end-tidal capnography available that was greater than 50% interpretal during that minute. Then we stratified our analysis on the witness status, and this is because our question is about time. So the reliability of time is different between a witnessed and an unwitnessed event. Then we used propensity scores to balance our capnography trajectories on the classic Utstein criteria that are listed here. We followed up using inverse probability of treatment weighting and logistic regression to determine the temporal associations of capnography trajectory and outcomes from cardiac arrest. For the purposes of this talk, I'm going to focus on ROSC and show those to you. Of the 3,004 patients that were enrolled in the PART trial, 1,172 had capnography available for us to analyze. Of these, 452 had a witnessed cardiac arrest, 716 had an unwitnessed cardiac arrest. In this sub-analysis and each of the strata, they represented the typical cardiac arrest patient in the United States. And so that is a primarily male of white race with a non-public, non-shockable cardiac arrest. When we begin to analyze our capnography trajectories, we were actually able to further classify our witness cardiac arrest into 3 clinical phenotypes, essentially. So for our witness cardiac arrest, they were characterized either into an initial capnography value being low, moderate, or high. All of our unwitnessed cardiac arrest group-based trajectories performed uniformly, so those will be presented as one cohort. So in the coming slides, I'm going to present 4 cardiac phenotypes to you guys. So this is our first cardiac arrest phenotype. This is for a witnessed cardiac arrest with an initial capnography value in the low ranges. On the x-axis, what we have is time going forward over resuscitation up to 30 minutes. On the y-axis, we have the risk of ROSC. So this is a little bit unconventional. It's the risk of getting a pulse back, so this is a good thing. The higher the number, the better. In pink, I have patients who have an upward trajectory of capnography values. And in purple, I have patients who have a downward capnography trajectory. And what we can see is that as we resuscitate, the likelihood or the risk of getting ROSC back increases, which makes sense. When I start to get a clear divergence of an upward capnography trajectory patient from a downward capnography trajectory patient is after 8 minutes of resuscitation. Such that in this specific data set, what we see is that after 8 minutes of resuscitation, an upward capnography trajectory patient has about 3 times the risk of getting ROSC compared to a downward capnography trajectory patient. This is our second cardiac arrest phenotype. So this is for a witnessed cardiac arrest with an initial capnography value in the moderate ranges. Again, on the x-axis, I have time going forward over a resuscitation up to 30 minutes. And then on the y-axis, I have the risk of obtaining ROSC. And in pink, I have my upward capnography trajectory patients, and in purple, I have my downward capnography trajectory patients. I begin to see a clear divergence of upward capnography trajectory patients after 12 minutes of resuscitation, such that they have about double the likelihood of getting ROSC compared to a downward capnography trajectory patient. Here's our third cardiac arrest phenotype. This is for a witnessed cardiac arrest with an initial capnography value in the high ranges. Again, I have time on the x-axis and then the risk of ROSC on the y-axis. I begin to see a clear divergence of an upward capnography trajectory patient after 21 minutes of resuscitation. And for our fourth cardiac arrest phenotype, this is the unwitnessed cardiac arrest. All of those capnography groups performed uniformly, so they are presented as one cohort. And what we can see here is that an upward capnography trajectory patient clearly diverges from a downward capnography trajectory patient after 7 minutes of resuscitation. So these are all of the clinical trajectory divergence times. And we can see anywhere from 7 to 21 minutes of capnography observation time is needed to diverge an upward capnography patient from a downward capnography patient. And these were all based on the initial characteristics of the cardiac arrest. There are some limitations that we do need to consider when we think about this data. One, the capnography values do include a handful of bag valve mask ventilations. Two, the capnography values were not adjusted by ventilation rates or chest compression rates, which are known to affect capnography values. So in conclusion, dynamic time-varying changes in capnography may guide resuscitation decisions. Anywhere between 7 to 21 minutes of capnography observation time is needed to clearly differentiate an upward trending capnography patient from a downward capnography trending patient and associate these with outcomes. And importantly, these time points varied based on initial cardiac arrest characteristics. And with that, I'd like to thank a large group of individuals who've helped continue to guide these projects and make them better and improve me as well. And then also thank SAEM, and I welcome any discussion after the talks. Thank you.
Thank you, Dr. Nassal.